Welcome to this peer voice activity on Thymidine Kinase 2 deficiency, featuring an expert and a patient advocate. At any time you may download supporting materials and share this activity with colleagues.
Hello, and thank you for joining us. I'm Dr. Caterina Garone from the University of Bologna in Italy. I'm so pleased to be joined by Mrs. Noemi Speroni, psychologist and diagnosed with TK2D. Welcome to this educational activity, Unveiling TK2D, what every patient needs every clinician to know. TK2 deficiency is an autosomal recessive and progressive mitochondrial DNA maintenance disorder with a wide range of clinical presentation. It can appear as a severe disease in infancy or as a milder form later in childhood and adult, leading to delayed diagnosis. Improving recognition is essential as accurate diagnosis guide management and is increasingly important with the availability of disease-specific therapy. Mitochondria is essential for energy production and require replication of the mitochondrial DNA. TK2 activity is essential for maintaining balanced mitochondrial nucleotide pool required for normal mitochondrial DNA replication. Lack of TK2 activity causes imbalance of level of DNTP and cause qualitative and quantitative defect of the mitochondrial DNA, consequently impacting the respiratory chain activity. TK2D is a muscle-specific disorder with a progressive and severe muscle weakness which can impact the ability to walk, eat, and breathe independently. The clinical spectrum is associated with a molecular genetic spectrum, with patients that have age at onset less than 12 years presenting severe reduction of mitochondrial DNA copy number, also called mitochondrial DNA depletion. Patients with later onset after 12 years essentially present mitochondrial DNA multiple deletion. We had the opportunity to survey 32 patients with TK2D, and we learned that TK2D impacts basic kidney health, breathing, development, and sometimes even cognition. And now please answer this challenge question. Noemi, we are so grateful to have you with us today. TK2D is an extremely rare disease, and having the opportunity to hear directly from someone living with it is incredibly valuable. Noemi, can you share when your symptoms began and what that time felt like for you personally?
My symptoms began when I was around 12 years old. I remember having strong pain in my legs and feeling constantly exhausted. On particularly tiring days, I would even fall because my body simply could not keep up. I was not diagnosed until I was 18. My symptoms came and went unpredictably, and since this is a degenerative disease, the progression was very slow. That made it even harder to identify early. Living for years without knowing what was happening was extremely frustrating. I felt misunderstood, and at some point, I even started to believe that maybe it was all up in my head, that I was exaggerating. That feeling was one of the hardest parts of my journey.
Do you mind to share with how you learned about TK2D?
Yes. I first learned about TK2D when my brother was diagnosed in 2006. He was 2 years old and I was 4. His condition has always been much more severe than mine, and his symptoms are completely different. Because of that, no one ever considered the possibility that I could have the same disease. We did not speak openly about it at home, but I was always aware of how serious it was. Years later, when treatment became available, our lives gradually improved. However, when I received my diagnosis in 2020, it felt like a hurricane had hit our family once again.
Thanks, Noemi. What was your experience once you had the symptoms?
I honestly do not remember life without symptoms. I have lived with chronic pain since I was about 12 or 13. I was always a very active girl, but by the age of 16, I had to stop many activities until I turned 18 and I could not even ride a bicycle anymore. Over the time, the pain simply became my normal.
So in this journey, Noemi, what kind of support or coordinated care was the most helpful for you? What was the most important to prepare as you look ahead?
So, as a psychologist, the first thing I considered essential was psychotherapy. I needed support to accept my diagnosis and to learn how to live with chronic pain. Over the past 5 years, I've had to discover how my body works. For 18 years, I was living a normal life, and then suddenly I entered a new reality of medication, therapies, and finally having a name for my pain. In a way, my diagnosis gave me relief. It gave me answers after years of doubt. More recently, I introduced physical training into my routine. I tried gym, swimming, and now I practice Pilates twice a week. The combination of psychotherapy, medication, and a healthy lifestyle allows me to live a nearly normal life. I can do almost everything, and for me, that is what truly matters.
Thank you, Noemi. Your story highlights how challenging and delayed diagnosis can be. On that note, we'll start to review how practically identifying this patient earlier. So thymidine kinase 2 deficiency is to be considered when a patient has a sign or symptom of the disease, or when we have a genetically undefined neuromuscular disorder or isolated CK. Biomarkers for this disease are an increase of lactic acid and plasma alanine, as many other mitochondrial disorders. But TK2D also have an increase of CK level, which is very rare in mitochondrial disease. When available, GDF15 level is also very important. The increase of GDF15 correlated with the disease severity. Muscle biopsy in patients with thymidine kinase 2D can show dystrophic changes together with histochemical abnormality that are in general the presence of cytochrome oxidase deficient fiber and an increase instead of the succinate dehydrogenase activity. Muscle biopsy is also important because we can analyze the level of mitochondrial DNA copy number and the quality of mitochondrial DNA so we can identify depletion and multiple deletion. In muscle homogenate, we can also analyze the respiratory chain activity and demonstrate a multiple oxphos deficiency. The diagnosis is only confirmed by genetic testing, so identify BLL pathogenic variant in TK2 gene. And this can be done with NGS panel if those panels include TK2 gene or with whole exome and whole genome sequencing. And now please answer this challenge question. Noemi, thank you so much for sharing your experience with us today. Your perspective brings invaluable insight into the real-world impact of the disease. So stay tuned as we take a closer look at how TK2D present across different ages of onset as we explore each presentation in the following macro episode. Hello, I'm Dr. Caterina Garone. In TK2 deficiency, with age onset less than 2 years, infant may appear healthy at birth, but rapidly lose motor milestone and develop respiratory failure within the first year of life. This is a progressive and life-threatening disease with high mortality. High clinical suspicion and prompt diagnosis are essential to prevent further irreversible damage, especially with the availability of the disease-specific treatment. In this episode, we review the key clinical clues that can help distinguish it from other early-onset neuromuscular conditions. When TK2D have an age at onset less than 2 years, patients might achieve the ability to control the head and to have a sitting position, but then they develop early and severe hypotonia and proximal muscle weakness, so they lose those ability. They also develop rapidly progressive respiratory failure, which is the most common cause of death. As additional signs and symptoms, they might experience seizure between 2 or 3 months after the disease onset, encephalopathy, cognitive deterioration, and sensory neural deafness. Some patients have also hypertrophic cardiomyopathy, and they might develop multiple bone fractures. The post-onset survival in this group of patients is extremely reduced, and the majority of them die within 1 year from the disease onset. So let's compare TK2D from one of the most close neuromuscular disorders, which is spinal muscle atrophy type 1. As you can see, although the age at onset in TK2D is less than 1 year compared to 6 months for SMA type 1, the disease is rapidly progressive in infantile-onset TK2D. There are no prenatal signs, and hypotonia at birth is very rare. Also, if we consider tongue fasciculation that are common in SMA type 1, those are absent in infantile TK2D. CNS involvement, which is absent in SMA type 1, can be present in 30% of patients when the disease onset of TK2D is less than 2 years. Both disorders share respiratory involvement, but in TK2D is early and severe. Here, I like to present an 8-month-old clinical case with TK2D. This patient had a normal psychomotor development up to 5 months of life, but then he lost the ability to roll over and to control his head. He developed hypertrophic cardiomyopathy, and he also had focal migrating seizures. Those seizures were subdued, and they were just stereotyped chronic movement of the mouth, shoulder, and fingers. The patient had brain encephalopathy with increased T2 lesion in the bilateral insular region and cortical subcortical atrophy. As you can see here, the brain MRI lesion rapidly progressed within 3 months from the disease onset. And when we had chance to analyze with the spectroscopy those lesions, we also identify a peak of lactate, showing how severe was the mitochondrial disease. And now please answer this challenge question. To conclude, the key clinical feature of infantile TK2D is the regression of previously acquired motor milestone, and specifically head control and sitting position. They also have CNS involvement in 30% of cases, and they have a severe respiratory failure. The genetic hallmark, together with the B-allelic variant in TK2 gene, it's a severe mitochondrial depletion in muscle. Thank you for watching. Hello, I'm Dr. Caterina Garone, and I'm joined by Noemi Speroni. When TK2 deficiency starts between 2 and 12 years of age, children develop progressive muscle weakness and they may lose the ability to walk and breathe independently. This decline is reversible and worsens over time. Early diagnosis is essential as every delay can lead to further irreversible decline. And high clinical suspicion is now more important than ever, especially with the target treatment available. So when we have a childhood-onset of TK2 deficiency, patient might present growth failure, progressive muscle weakness, and loss or delay of previously acquired motor milestone. When they come to our clinic, we might notice a positive Gower sign. In terms of ability, they might lose the ability to walk, to stand without support, to step on stairs, or raise arms. In terms of additional signs and symptoms, muscle is the most involved, with bulbar and facial weakness, myalgia, or exercise intolerance. Patients may also experience weakness in the eye muscle with progressive external ophthalmoplegia and ptosis. Instead, a CNS or multisystemic involvement is very rare. So let's start with Leonardo clinical history. He had a normal psychomotor development in the first 2 years of life, but then he started to have frequent fall and progressive difficulty in climbing stairs. His facial muscle became very weak, and he also had dysphagia. In terms of respiratory function, he had a frequent respiratory infection since age 2. He had an increase of transaminase and CK, but the first hypothesis was spinal muscle atrophy type 3, and the genetic test became negative. We performed a muscle biopsy that showed that muscle fibers were COX deficient. And then we suspected a mitochondrial maintenance disorder because the level of mitochondrial DNA copy number was consistent with mitochondrial DNA depletion. The genetic testing showed compound heterozygous variant in TK2 gene confirming TK2 deficiency. The disease progressed, and when he was 8 years old, he lost ambulation. But we had a chance to start compassionate use, and he regained the ability to walk. Before that time, he was not able to run a 6-minute walking test, but then progressively we increased the number of meters that he was able to achieve during the test. Now he's 21 years old, and I like to ask Noemi what his brother like today.
Thank you, Dr. Garone. The only thing that I want to underline today here is how he got so independent. And the most important thing is that he drives his car. He has a very big social life. He goes out with his friends. He has a big group. He goes on holidays with his friends. And he also goes to university. He wants to be working with the football. And he is very independent nowadays. So he's free to be home alone. It was not possible at first. And we're very happy with how he is growing up.
And now, please answer this challenge question. So TK2D, when has a childhood onset between 2 and 12 years, is characterized by progressive myopathy without cognitive delay. The disease might mimic spinal muscle atrophy or a limb girdle weakness, so diagnosis is very important. Patient may experience ocular and bulbar feature and fatigue and exercise intolerance, whereas other symptoms in other organ and system are very rare. In terms of genetic hallmark, together with TK2 gene variant, we have a marked muscle mitochondrial DNA depletion. Thank you for watching. Hello, I'm Dr. Caterina Garone. Adult-onset TK2 deficiency present with progressive muscle weakness beginning in adolescence or adult. Patients often develop facial weakness, scapular weak, ptosis, and respiratory complications, while many remain ambulatory for years. Because symptoms progress slowly and may be overlooked early in life, high clinical suspicion and accurate diagnosis are essential for appropriate management and genetic counseling. When TK2 deficiency have an onset after 12 years, the disease has a very slow progression. For this reason, it is very important to have a detailed clinical history. Patient might not report muscle weakness early in life, or they might have underestimated their symptoms. But if you make a clear question, they will report you that they were feeling less sportive or less active, respect to their friends, and they might not be able to have a complete social life and independence. When disease is fully symptomatic, the clinical pattern of patient is characterized by progressive external ophthalmoplegia and ptosis with a variable degree of proximal limb weakness. In 70% of cases, we also have some clinical sensory neuropathy. Similar to muscle weakness, the respiratory involvement may be very early in life, but this difficult might not be reported to the clinical doctor, and so they are progressive, and in 72% of patients require mechanical ventilation when they are adult. Here I like to present the clinical history of a 74-year-old woman. She had an history of a sensory neuronal hearing loss, but then she developed progressive muscle weakness over several years. She had 2 surgical correction of ptosis and respiratory failure requiring ventilatory support. When she came to neurology consultation, she had mild bilateral ptosis, progressive external ophthalmoplegia, and muscle wasting. In terms of proximal lower limb weakness, as example is hip flexion where MRC grade 2. Instead, tendon reflex were preserved and she had no ataxia. We performed muscle biopsy that show 20% of COX-deficient fiber. Genetic testing with a panel for gene commonly associated for maintenance of mitochondrial DNA show a compound heterozygous variant in the TK2 gene. And now please answer this challenge question. In adult-onset TK2D, the most important clinical clue are ptosis and progressive external ophthalmoplegia. Patients might have variable proximal weakness and they lose the ability to take care of themselves. In some cases, we might have isolated exercise intolerant or isolated hyper-CK. It's important to notice that they also have respiratory involvement with nocturnal hypoventilation. The genetic hallmark, together with TK2 gene variant, is the presence of mitochondrial DNA deletion, and in some cases, a variable reduction of the copy number. Thank you for watching. Hello, I'm Dr. Caterina Garone. In this final episode, we return to Noemi's story, which shows how differently TK2 deficiency can present even within the same family. Her brother was diagnosed in early childhood, while Noemi's symptoms began later, and her diagnosis was delayed because TK2 deficiency was not initially suspected due to their different presentation. Age of onset and timing of diagnosis shape the clinical course and outcome. Recognizing the sign early is essential, as delayed diagnosis can lead to preventable and irreversible disease progression. Noemi started to have first sign of the disease between 12 and 14 years of age. By the way of adult, she felt knee pain, and after muscle weakness and some difficulty in respiration. The very first hypothesis was an inflammatory disorder like rheumatoid arthritis. The disease progression was very slow. She never lost the ambulation and she preserved the function and independence. But the laboratory testing showed an increase of CK together with transaminase. And although her clinical picture was very different from her brother, we consider TK2D as a potential diagnosis. Noemi, would you like to describe what knee pain means for you?
Yes. So usually the pain that I feel is kind of burning, and I feel a lot of weight on my legs, and it's hard for me to walk and do everything. Usually the pain doesn't stay only on my legs, but it goes up to my arms and every muscle that I have. If the pain is very strong, I cannot eat because also my face muscles hurt.
In this video, you will appreciate the difference in terms of clinical course between Leonardo and Noemi. We like to highlight how two brother and sister that share the same genetic variant have a completely different age of onset and disease score. And now please answer this challenge question. Noemi, what's your understanding regarding the diagnostic delay? Why do you think there been such a diagnostic delay in your case?
In Italy, genetic testing is generally not performed before the age of 18 unless there are very clear and specific symptoms. My symptoms were inconsistent and very different from my brother's, so my parents never thought about genetic testing. What I find most significant is that no doctor who knew our family history ever considered the possibility that I might have the same disease. Part of the delay was due to a lack of awareness about how variable the symptoms of the same condition can be. Another part was simply the assumption that such a rare disease could not appear twice in the same family in such different ways.
So, as a family affected with TIC2D, what would you like the medical community to understand?
I believe it is essential to truly listen to patients and never minimize their experiences. Every symptom should be taken seriously, even when it seems unlikely. Early diagnosis can make a profound difference, especially in degenerative conditions like mine. I often wonder how different my life might have been if I had been diagnosed at 12 instead of 18. Starting treatment earlier could have slowed the progression sooner and reduced some of the limitations I live with today. Timing truly matters.
As a conclusion remark for this educational activity, I like to highlight the unmet need of diagnosis TK2D. While we are setting a newborn screening, prompt recognition and rapid access to genetic tests is very important. Clinicians must consider if NGS panel include TK2 gene and refer patients to geneticists, especially in presence of variants of uncertain significance. A multidisciplinary management is very important and must include a TK2D expert, but also pulmonologist, physical therapist, child and adult neurologist, cardiologist, and expert in nutrition. Thank you for watching.
This has been an activity published by Peer Voice.